So this, I was talking to Sonal that this session is basically for all you guys. Whatever you have learned in this session, 1A and 1B. So it is because Sonal is acting as Amitabh Bachchan and you are going to, all of you are going to become Gyanpati. It's not Karodpati because she's just giving 5 rupees 5 stars. So whenever there will be some rapid fire questions also, that those are the questions which have already been covered by our previous speakers, and whosoever wants to answer, don't prompt, just raise your hands and our Amitabh Bachchans will come to you. Right. So the first one, how far away as minimum from the gingival margin should your incision be? See, the idea is repetition, repetition and repetition so that all of you know. 5 millimeters. And for IVRO? And if the incision is for IVRO, then?
8 to 10. Yeah, you can say.
If the incision is for IVRO?
Sir, whom do you want? Sir?
No.
More laterally.
So how many millimeters?
8 to 10.
More than 2 to 3.
Sir, there? Yes.
You said 2 to 3 mm?
I said 10 mm.
You said no.
There?
That's not
You
good.
already done.
So Mustafa sir, could you repeat again?
It is less than the regular buccal incision. It's around 2 to 3 millimeters.
Yeah. So next question, rapid fire. What are the 2 nerves are at risk here? One is on the other side, the yellow one, and the other one is.
Okay.
Raise your hands.
Okay, there.
Lingual and long buccal nerve.
Lingual and long buccal nerve.
That
Right.
is a long, better answer. There's no way it's better reach that.
It's actually sensory long buccal nerve because that's the only. So another one. So everyone knows what is this nerve, right?
Yes.
The mental nerve. So now the 3 branches near which facial muscle you have to identify during the intraoral approach. When you go to the body of the mandible or which muscle?
No, not her. Not her. Take the mic, Bache.
So it
Depressor angula oris.
correct. So it is depressor anguli oris. Like when the nerve divides into 3 cutaneous branches, you have to identify the depressor anguli oris. This is a multiple choice. At the level of lingula, everyone knows where lingula is. The inferior alveolar artery and vein are located in relation to inferior alveolar nerve. Like these are the choices: anterior, medial, posterior, and superior. Raise your hands. Very few hands.
No, you have already answered.
You have already answered. So the relationship of inferior alveolar nerve with the inferior alveolar artery and vein at the level of lingula.
It is anterior.
What is somebody will be? Who is anterior?
Who is anterior? Okay. Anybody else? There will be other 3, no? Fast.
Yes.
Ma'am, vein is superior and artery is left.
No, you just have to answer A, B, C, D.
D superior.
Okay. So it is posterior basically. So the inferior alveolar artery and vein is posterior and nerve is anterior. So there are some considerations during the orthognathic surgery. Dr. Mustafa will put a light on that. Sir, mic to sir. When we have to make a horizontal cut. So this relationship is very important.
So when you want to make the horizontal cut, what you need to do is try and locate the lingula. Okay, it's a triangular shaped structure, and make the cut just above the lingula. You are very safe. There is no chance of damaging the nerve or anything like that. Because the relationship of the lingula will determine whether your cut is going to cause any damage to the nerve. And
Yes, sir.
one more, we want to discuss about the...
Yeah, so the position of inferior alveolar nerve in the proximal segment and distal segment will also be related to this.
Related to. So that if you want to avoid that, you can actually assess it if you have a CT scan. These days, CBCT is easily available. So you will be able to locate whether the nerve, once it enters the mandible, whether it is more lingual or more medial or more lateral. And based on that, you may have to make the cuts. So once you know the position, then everything depends on how you direct your osteotomes. And also it will give you the superior inferior position of the nerve as well when it transverses and comes down, because it will usually descend down, you know, once it enters the canal.
Yeah. So anybody wants to clarify anything here? It is the chance here.
As we said, the identification of this mark, if you have a virtual surgical planning, what we used to do is to print a model, just make an acrylic splint, just pointing towards on the upper part of the lingual. It can be easily adapted on the lower molar, so that can be done. Otherwise, you can do a surgical cutting guide as well, with just two, like a occlusal splint, which just extends and then reach the level of the lingula, so that you can make a cut on top of it.
So did you get it?
That's all.
Like if you want to be more safer, we can take the help of technology. We can get the CT scan images, get the DICOM files and send it for virtual surgical planning and make a stent which can be fixed onto the third molar or second molar and first molar, and then through that stent you can, after giving the incision, you can fix the stent and safely you can
I have the pictures. I'll
give
show
your
you maybe in the
incision.
next.
Okay.
The
Right.
NBB shows the NBB, right? That is the order. That's why it's called as neurovascular. Nervous on top, right? That's how we remember.
Yeah, right. So the next question. This is again an MCQ.
One more thing.
Yeah, one more point.
Now, I was talking about the vestibular incision for IVRO. Now, if you want to do an angle osteotomy or angle ostectomy, it is called, if you want to reduce the angle, then your dissection has to go still posterior and inferior, and because there the attachment is very tight, so you may have to strip the masseter muscle there, and then once you have done adequate exposure, you can do the angle ostectomy with the help of a reciprocating saw. So those are some of the variations. Variations are not in terms of the incision per se. Variation is in terms of the exposure. So you may have to extend the incision a little further posteriorly if you want more exposure at the posterior border of the rings.
Right. So the next question, the whole idea is repetition, 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 so that you know and learn better. So again, this is for the marginal mandibular branch. So when performing a submandibular approach for the angle fracture, which of the following is true? Anybody? Raise your hands. C is true. Okay. So he is right. Yeah. So I am explaining it. See, there are two articles. There are two major studies, one by Atkinson and one by Dingman and Graf. So, if we divide the marginal mandibular branch position, that is in relation to the facial artery and vein. Facial artery is a mark, and marginal mandibular behind has got different relations, and anterior to that has got different relations, right? So, in 21% of the time, marginal mandibular branch has got single branch. In 67% of the time, there are two branches, 9% 3%, 4 branches of marginal mandibular branch of facial nerve, and most of the times, in 19% of the time, it is seen that it runs below the lower border of the mandible, that too in the anterior part, that too in the anterior to the facial artery, and most of the times, in 81% of the times, it is above the inferior border of the mandible. But to prevent injury in those 19% of patients, we always give incision 2 cm below the inferior border of the mandible. Is that clear? So this is what we wanted to give you an insight of, right? Name a technique to avoid the marginal mandibular nerve. Somebody prompted beforehand. Yeah. So it is
Hayes-Martin procedure.
Hayes-Martin. So Hayes-Martin procedure is like we were discussing. Andy sir, would you put some light on that? That we were discussing that if you go on searching for the nerve, you are going to damage it. Okay. So Hayes-Martin incision is
Yeah, I mean,
Hayes-Martin
essentially,
approach.
The Hayes-Martin approach is a standard approach. You all know it was talked about earlier, basically. And it's basically just identifying where the facial vein is. And again, it says 2 finger breadths below there. And that's from a textbook, you know, and I talked about the fact I don't like finger breadths, basically. But then when you flip the vein, you know, flip it up, the idea is it's retracting that superior cervical fascia, and that's where you find the nerve running in that 19% of cases where it runs down. You're flipping it back up the way, and as you flip it back up the way, it's safe, basically, yeah? But you can see there, that's a wide exposure, yeah? Don't go down a deep dark hole because you won't see anything, basically, yeah? Colorado needle's fantastic. I use them all the time. Tungsten tip Colorado needle on cut only. Don't use it on coag, use it on cut only, and you get beautiful dissection done with that, basically. So I would advocate using that. And if your anaesthetist hasn't paralysed the patient, you can actually see the nerve twitch when you get close to it as well. So that's again another thing, but don't use that as a technique. Please don't. Yeah.
So the another approach is the sandwich technique, that you identify the fascia of the submandibular gland and incise the fascia and raise the whole fascia upwards, and the marginal mandibular branch gets sandwiched into that fascia, and you can retract it upwards and you can do the procedure. So in that way, you are not going to identify the marginal mandibular branch of fascia nerve, but you are sandwiching that nerve between the layers of fascia and above the vascular plane, and then you retract it and then you can do your procedure. In that case, the chances of injury to the marginal mandibular nerve are very, very minimal. Right? Yeah. Mike.
We are doing neck dissection, the area is quite open up, right? You can take a weight gauze, just press on the submandibular fossa, the nerve tries to pop up. It's a very
a very valid point, but we are discussing here the mandibular incisions, not the neck dissection incisions.
You can do it here also.
Yeah, we can tell our nurse or our assistant to keep on irrigating it. Okay, with the saline. That is also one thing, because with the irrigation, the nerve gets nerve is more visible in between the facial planes. And always remember, the nerve makes a loop around the mandible in the inferior border. It makes a loop around the mandible. So whatever dissection, Dr. Rahul has to add something here.
Yeah, I think Hayes-Martin is a very popular maneuver. But if one is doing a benign pathology or a fracture, there are 2 schools of thought, like Dr. Sonal said, that she likes to identify the nerve. The good point is that you are safe once you know where the nerve is. The other issue with the marginal mandibular nerve, it's a very sensitive branch of the 5 branches. The buccal is the least sensitive and the least helpful for facial expression. The marginal mandibular, the most sensitive. So the moment you handle it, you are sure to get paresis, even if you have dissected out. So if you are sure that you are cutting the investing layer of deep cervical fascia, it's a nice thick fascia, then you are safe with the nerve.
Right, thank you, sir. So again, rapid fire. A, B and C. Which ligament is attached to A? No, don't prompt, just raise your hands. Okay. Yeah, sphenomandibular. So the sphenomandibular ligament from the spinous process of the sphenoid bone and then comes over to the lingula. Which nerve is related to groove B? This one. This is the groove B.
If you don't want chocolates, everybody can give the answer.
No problem. We will spread the chocolates here. Whosoever prompts, prompt and come and pick the chocolate and go back. Anyway, so yes, it is the nerve to the mylohyoid. Rapid fire. Which muscle is attached to line C? Mylohyoid. And which nerve supplies the D? Incisive. So it was too basic. So yeah. So now coming to Lakshmi, in your case, Lakshmi has shown a procedure in the floor of the mouth for the removal of a large silolith, isn't it? And somebody has asked about the incision of the large silolith. But that was a large silolith which can be palpated in the oral cavity. But in case of a small silolith, this is not a silolith, by the way, this is just inflammation of the caruncle. but the cylolith is there in the submandibular duct, a very small cylolith of about 4 millimeters to 5 millimeters. Why I know? Because this is my son's intraoral picture. He had a cylolith. So now what is the way to incise in those cases? Remember the lingual nerve anatomy. Okay, and can anybody tell the direction of the incision in the floor of the mouth for these kind of lesions? Parallel to the duct. But can you tell the direction? Posterior to?
Posterior anterior.
Posterior anterior. Right. So, Lakshmi.
Thank you.
Now you.
They were asking about the closure. I think.
Yeah.
And, she was asking whether how should we go about closing it now, since it's a.
Who was asking this question about the closure? Yeah.
So that's a functional duct which is being blocked by the calculi, and in that case that we had shown right in the morning, that was a huge calculi that was staying in that patient's mouth for the last 10 years. So there's a lot of inflammation and the duct is open, because once you remove the calculi, you know, kind of an area where it might require a kind of a marsupialization kind of a picture. So in that case, you could give a primary closure after you repair the duct, but then the dead space is about a centimeter long in that particular patient. So we had to take a layer closure. You can put a stent so that normal functioning of the duct is restored.
So you have to be see when you are removing the stone. When you have removed the stone, after that you have to recanalize the duct. So this procedure is about the recannulation of the Wharton's duct. And if you think that the recannulation also could not improve the stricture, or if beforehand you have done any ultrasonography or any imaging, and if there is a stricture, then as Lakshmi has said, you can very well put a stent there, okay, a Teflon stent there, and keep it there for irrigation, for the patency of the duct. You don't need to close the duct. You can do a superficial mucosal closure, and that will work well. Okay. Otherwise, if you don't cannulate and if you don't put a stent there, it might as well go for the stricture formation in the future, and the cylolith formation will be recurrent. Is there anything somebody wants?
Just be careful when you're stitching the duct. That duct's very small, 1.7 millimeters to 2. If you put sutures in it, make sure they're very, very fine. A microsuture is great. I was doing it using 7/0 monofilament. Be careful, because as Amit says, that duct will get a stricture, and that's the last thing you want, basically, because then you're into doing all sorts of weird operations on the duct, trying to transposition, ductoplasty, stenting it and stuff. So just be very mindful when you're doing that. Either cannulate it and leave the stent, don't bother stitching the duct over it, just leave it, and it will re-epithelialize over it, basically. So just be mindful when you're stitching it. Don't put big 3/0 vicals or any nonsense like that. You'll scar it up, and it'll scar up, and it'll be horrible, and you'll end up having to either do something to the duct to try and retrieve that, or God forbid, you're going to have to go back and take the gland out, which is just...
So can you hold the mouth a little closer to your, because...
Okay, yeah, sorry.
Okay.
Can I have a slight differing opinion, and if you can have a comment back on that? There are so many people who will be starting their oral surgical careers. Is it fair enough just to remove the stone and close the mucosa loosely? There will be a pseudo opening wherever the duct has been, wherever the stone has been. The pseudo opening will take care. Instead of somebody trying to suture it with 9 or is that a fair opinion?
Yeah, absolutely. Yeah, if you don't put any sutures in and a small opening, it will recannulate. You'll find
an opening.
Don't worry about it if you can't put sutures in it. Definitely don't panic about it. There's a lot of ducts I've just put there and said, fine, just leave it, and maybe put a mucosal stitch in, and that's about it.
One problem which I faced was while removing the cylolith, I could find that the stone is moving little more posteriorly. So how to prevent it? Like
Lakshmi.
Those stay suture, how strong?
So I think in the video it was not, Now in this case, in that particular case that was shown, it was quite huge and it was well accessible. But generally, if it is, it's quite moderate in size, and you need to give some restriction behind the calculate. So the only way that you can do is pass a suture. Make sure that you do not pass the calculate should not go posterior to that, and you limit the calculate going inside the substance or posterior to the area of dissection.
Now, how to make sure that the suture is not going through
Yeah, that could be a difficult task, but then I think it's only the tactile that
you always use a round body needle. Don't use a cutting needle first thing, and then you have to identify the duct and pass the suture behind that to immobilize it. And always don't do the decannulation and cannulation and everything before removing the stone. Otherwise, you will push the stone back into the submandibular gland. Sir, you wanted to add something? Then we will move to the next because
short of time.
Yeah. No, it's okay. You can add.
The more posterior the stone, the more difficult it is, and especially when you're doing under general anesthesia, patient is relaxed. That's the problem. Then you have a very good assistant with good fingers who can really push. He will have painful fingers. The posterior stones are the problem. The anterior ones are very, very simple. And local anesthesia is the best way to remove a stone. If it's very posterior, then general anesthesia, and that's where one person's job is really push posteriorly at the myelohyoid. Your suture, you are really not sure that you are encompassing. It's more for traction than to stop the stone going behind. Exactly. It can still go in.
Yeah, I agree. Don't put one of these structures in. It does all sorts of nonsense. If you've got access to silendoscopy, that's another modus of doing that. You can do a basket retrieval of a stone. That's just if you have the equipment.
So we are coming to different scenarios now, for which you have already listened to in the morning. Factors affecting the choice of surgical approach. Now this is the which fracture it is? Angle fracture. So who will want to open this with extraoral? Raise your hands. Extraoral. Intraoral. Okay. And with transbuccal. Okay. So now majorly you would like to open this with the extraoral. Okay. Why?
The visibility and the access will be much more easier.
Okay, so this is what is the factor actually? Would you like your factor is visibility, access. Okay, okay, right. So whosoever wants to open intraoral. Why intraoral?
There is no displacement of the fragment.
Less of displacement. And transbuccal. Why transbuccal?
Because with transbuccal we have both the advantages of extraoral and intraoral.
With the transbuccal you have both the advantages of extraoral and intraoral. Andy sir, would you like to comment on that?
I mean, you try and avoid extraoral at all because that comes with risk, as you know. We're maxillofacial surgeons, we don't like scarring the face. Even though it's an extraoral scar, it's usually in the skin crease and stuff like that. If you can get access to intraorally, absolutely fine. I try to do most, if not all, my angle stroke, ramus stroke, body fractures intraorally. The only time I tend to go extraorally if it's a bad fracture, comminuted, or there's an existing laceration there or something like that. So, yeah, it gives you great access, but it comes with risk, and that's what you've got to be careful of.
Yeah, so there are two major factors. One is the degree of displacement, as you have mentioned, and the second thing is access. So, you wanted to add something?
Yeah, then we have a lot of oral submucous fibrosis here specifically. A lot in India, a lot more probably here and in the east around Calcutta and West Bengal. So in such cases where there is limited mouth opening, that can be another case.
Yeah.
I could be wrong, like if there is sort of playing on the lower border of the mandible, so it's very difficult to bring it together in such cases.
Exactly.
Poor oral hygiene. If the hygiene is poor, then
Sometimes, not all the cases, but sometimes. And for us in Bihar, Jharkhand, we have a lot of, like ma'am said, oral submucous fibrosis case. So directly, it's very difficult. The moment you open, rather than the incision, the tissue will tear itself. And you are in the wrong position and give a very bad scarring and bleeding all throughout. So it's always, suturing is also difficult, it's very, very tight. So that case, extraoral, sir. Spraying of lower water, sir doesn't agree.
I think the more the displacement, the easier it is to reduce. But SMF is an absolute indication because just not the mouth opening, the kind of refibrosis that you will cause to the patient will be terrible. But if it's a lower order comminution or a bad fracture, as sir said, then definitely. But displacement is I think it's more in the mind. You know, it's never a problem to do it intraoral fixation.
No, but
in fact, it's easier.
Sometimes, I'm just saying, a couple of cases.
If it is displaced more, then one of the easiest thing to do is fix the plate on the proximal segment and then reduce it. It will be easy for you to fix intraoral.
I was just, not that I do it very often, but I was thinking the access to the lower border and the lingual aspect, you get better extraorally sometimes. That's what I meant to say.
So point well taken. Actually, it is Dr. Rahul. There is another scenario in which you have bilateral angle fracture. On the left side, it is comminuted angle fracture. That too in the edentulous mandible. So now we don't have a guide of occlusion here. We don't have a guide of occlusion here, so that is the factor which we wanted to discuss here. So if there is a guide of occlusion, not much of the displacement, and the third thing is you have good armamentarium like a good trocar, cannula, transbuccal set. Everything is there. So you can very well go with the transbuccal intraoral approach. But in cases like this in which you have to see the inferior border for the anatomical reduction because there is no guide for the occlusion. So then so fixation that we are going to cover this thing also what Dr. Mustafa has said, that load bearing plate, that is an altogether different concept. For the load bearing plate, then your length of incision will also increase a little bit because these days we have locking plates also, because in the next case, this is a comminuted fracture what Dr. Sonal was also mentioning and Dr. Rahul. So this is a comminuted fracture of the mandible in which a lot of comminution is there, and either you can go through the existing laceration. If there is no existing laceration, you have to adopt an extraoral incision for this, for the reduction and fixation of the fracture like this. For example, you have to increase the length of your incision, and your dissection has to be in that manner that the bone parts are also visible, because it is a comminuted fracture with multiple bone segments. Then you have to adapt the reconstruction plate, because as Dr. Mustafa is mentioning, for the reconstruction plate at least 3 to 4 screws anterior to the fracture and 3 to 4 screws posterior to the fractures. To gain that exposure, your incision would be a little more. It will be stretched kind of an incision, and your retractors, your assistant has to be well trained for the retraction of all the facial planes. Anybody wants to ask anything on this or wants to add anything, sir? Yeah, Mike.
In intraoral incision, whatever the length of the incision, you cannot gain access to a huge area. You have to extend the incision. But with an extraoral, with a small incision, you can still play around and get a wider exposure within it. That's the fundamental difference between an
intraoral incision and the extraoral incision. Sonu?
Question, Now, intraoral incision, if say an incision is 1 centimeter long versus another incision is say 3 centimeters long, okay? Which one is going to heal faster? Same. Common sense. Therefore, if you want to place an incision, intraoral incision, please don't place a small incision. Okay, pulling, pushing, etc. will actually make ragged ends. That is what will make your incision take longer to heal. Alright, so if you need so much exposure, it's alright if you place so much of an incision. Whatever, within normal limits, okay? If you need so much exposure, don't place so much incision. Alright, this is as far as intraoral goes. Or on the side of a longer incision intraorally, it's alright. Extraoral is very hard to be careful.
Yeah. One question again. So if the last case Dr. Amit showed, if the what is the advantage of the extraoral incision when the mandible is edentulous and even shorter in height? Any kind of modified fixation you could do?
Okay, advantage and disadvantage both. Who is telling about the advantage? Anybody?
Smaller mandible, edentulous.
The periosteum will not be stripped so much in external.
You can do a suprafecta.
I won't throw it personally.
So you have opened altogether a different Pandora box. Now that is atrophic mandible.
Very good. Excellent.
So supraperiosteal dissection is also one of the option in your hand then. So what kind of an incision in this patient? Anybody? Extraoral, intraoral?
Extraoral.
Who is for extraoral? Okay. And who is for intraoral? Okay, Richa, you had mentioned about the submental incision. Yeah. So this is a, if you look at the pathology here, it is a multilocular lesion, kind of juvenile ossifying fibroma or ameloblastoma or sentinel giant cell tumor, and then we have to resect this tumor. So definitely we can do it intraorally as well as extraorally, but thinking about the reconstruction of the anterior part of the mandible, we should always plan these kind of tumors for resection through the extraoral incision, and that to the submental incision, which Dr. Richa has already shown in her presentation. Anyways, again, as Dr. Sonal has mentioned, incisions are same, but we have different scenarios. Now this is the lesion. Yeah.
In this case, had the lesion been smaller,
Yeah, please.
I just ask like, ma'am, sound correct?
Ask the audience now. Ask the
Yeah,
audience.
actually, like in this case, sir said extraoral incision.
charged.
She's charged. Like, yeah, getting charged too. So, if the lesion is smaller, sir said extraoral incision is better because we have to do reconstruction. So, if smaller pathology, what will we do? Still extraoral or intraoral?
Smaller pathology.
We can actually go below the lower border of the mandible and start reflecting on the lingual aspect also and remove the lesion. Less of scarring. She's a girl, she wouldn't like a scar on the face.
Yeah, so it depends upon the, again we are discussing about the factors. How would you decide between the incisions?
Boys like scars on the face.
Had it been the anterior midline fracture, it would have been an intraoral incision. Had it been a smaller benign lesion, which we could enucleate, okay, or which we could enucleate it or whatever, had intraoral incision. But lesions like these, in which we require reconstruction with some bone graft or fibula or whatever, we require an extraoral incision.
And nature of pathology or like
Nature of pathology, aggressive. There are few lesions which are benign, but there are few lesions which are benign aggressive lesions, and then there are malignant lesions. So altogether different story. So pathology of the mandible, ramus, body, anterior part, and intraorally you also see. Now we were talking about clavicular incision. We were talking about incisions 5 mm away from the attached gingiva. In intraorally here there is no point of giving clavicular incision because the lesion is coming intraorally also. So you have to, it is called a situationship. So you have to bring your expertise as in what kind of a situation you are dealing with. It's not only always go about the book. You have to go about the book, but it's not always go about the book that we have to give 2 cm incision only. No, we have learned in Gyan that only 2 cm incision, 5 mm away from the attached gingiva. But if you see a patient like this, so again you have to combine your incisions like intraoral and extraoral both. Sir, you wanted to add
I
something?
have a small point. See, these days an era of what they call it as minimally invasive, and that term is getting a lot of traction. They want to be minimally invasive. When you say minimally invasive, it's always the length of the incision. Having said that, the most important deciding factor for incision should be the access. What is the access you are going to gain? So whether you are going to get a good access with the intraoral incision, then stick to an intraoral incision. But your access is going to be compromised by putting an intraoral incision, then go for an extraoral incision. Having said that, scar should not be a criterion at all, considering that you are a max pack surgeon and you have a superior way of suturing the tissues. So you should not worry much about the scar.
Exactly, I was talking to
improve your suturing techniques, Don't, be in a hurry to suture, because what happens is closure is the last part of the game. So you tend to hurry. So take your time and put all the principles of suturing and make sure that you get a good closure. And that would reduce it.
And sir, you mentioned very nicely about the tissue handling also. That is why you split the mucosa and the muscular layer into separate layers. And he mentioned that when we are going to suture, actually there is only one layer. Muscular and mucosa are joined together. But when we are giving an incision, at that point of time we intentionally create two layers, so that it brings we bring the suturing into double layer closure, and the scarring would be little less.
Yeah, if I can add about the extraoral suturing. So that is why you have to think about the suturing and then do your dissection. So it has to be a nice, neat skin subcutaneous tissue, a neat platysma and a neat masseter. Okay, you have to, and then when you are suturing, it has to be a neat closure of the masseter. And then when you finish the masseter and when you put back your facial artery, vein and nerve, then you have to have a nice layer of platysma visible that you can close, and then your skin. Okay, so you have to leave the body in the same way that you found it. As a ghichi nahi chahiye, you don't want a tunnel, you don't want all of that. Okay, if the incision is so much, again, the dissection and what you see inside should be so much. Okay, because you've dissected here and you've dissected here. It shouldn't be that your incision is so much, but you've tunneled and gone like this, and you can see only so much.
Andy sir, you have recently attended a minimally invasive orthodontic surgery.
Oh God, yeah, I've just come back from Dubai.
So would you like to comment on minimally invasive incisions?
Interesting. I've actually got some of the incisions to show you tomorrow when we go into the maxilla. So you'll actually see what they mean by minimally invasive orthodontic surgery. It's come from America, and mainly South America and Latin America, basically. To me, it looks like a gimmick, a selling point, but they sell it very well. It was a very shiny 2-day presentation and stuff like that. And I'll show you some of the incisions that they were able to do what I would do conventional orthodontic surgery, which is a LaFleur osteotomy, a genioplasty, and a mandibular ramus stroke angle orthodontic procedure. But yes, I'll show you them tomorrow, which you can make your own mind up. I've made my own mind up. Not for me, I'm afraid. Yeah, I don't know. I went away yesterday, flew back on the plane this morning. I was thinking about it, thinking, will I try it? And I might try and persuade my hospital to buy me some of the instruments, but I'm not convinced about it. It's a very nice presentation, a nice 2 days in Dubai, but otherwise, no.
Yeah. Thank you.
Just one thing I have to ask everybody. Like when we are doing the neck closure, there is a misconception like deeper layer suturing you have done. When you come to the skin, should we do interrupted suture or a subacute suture? Is subacute suture weaker than the normal interrupted suture? I'm asking. And even all of you also.
Anybody? Is subacute suture is weaker than the interrupted suture?
Especially in the neck.
No.
No, you're right, Mr.
The only problem is if there is an interrupted suture, for example, if you have a hematoma or anything, you can remove 2 stitches. You can't do that with a subacute.
The strength in your layers, yeah, that's where you're getting the strength from. All you're doing is approximating skin edges. There's no strength in there. All you're doing is approximating them here, so you have a nice scar, basically. I go for subcuticular. I use tissue glue a lot. It gives me a great result. I don't use any continuous stitches. It's a subcuticular I use all the time, and I use tissue glue. It's a technique I picked up doing plastic surgery. It works quite well.
Again, it is again a different situation. For example, if we are talking about the suturing of a neck dissection, then probably subcuticular we would not do, because we have to reopen sometimes if there is any hematoma. But for such cases like benign things, benign tumors and benign pathologies, we can always go for. I would prefer subcuticular on the face, and I would prefer subcuticular on for smaller incisions rather than for larger incisions of more than 3 centimeters or 4 centimeters. I would like Dr. Rahul to. So, quick raise of hands because Sonal has given me ghanti. So, what is this condition? Anybody? Raise your hand. Tell me. This is parotid swelling. Okay. Pterygomandibular space infection, right? Lateral pharyngeal, not laryngeal. Larynx is deep down. Okay, lateral pharyngeal, very good. Anybody else?
Peritonsillar abscess.
Peritonsillar abscess. Tonsil is little down. Tonsil is clearly visible. Okay, this is uvula. If you go down anterior fascial pillar, posterior tonsil is still not visible. But if we retract the tongue, tonsil will be visible. Okay, peritonsil, quinsy, you mean to say? Okay, anybody? It is. See, we are discussing here about the differential of this particular case. It can be a tumor. It can be an infection. It can be anything related to collection, hematoma, whatever. Okay, so now how would you diagnose this condition? This is clinical, and now how would you go about it? What investigation? Anybody? Any investigations?
Yes.
USG. Okay. What would you find in ultrasonography? Okay, type of collection. That's it. You will only get to know about the type of collection. Any more information if you want to know? CECT, contrast enhanced CT scan. The third one? That girl. Okay, the third one? Anybody else? For soft tissue? MRI. Right. So, see, this can be a pharyngeal mass, lateral pharyngeal mass. This can be a pharyngeal infection, as Dr. Andrew was showing in his presentation about the different incisions of the pharyngeal, this thing, though it was a tumor of the parapharyngeal space. Can anybody tell me the boundaries of the parapharyngeal space? Anyone? If somebody can. Otherwise it's okay. It's an inverted cone shaped space. Anybody? Okay, contents. There are important neurovascular structures like right from the skull base up to the part of the neck. We have carotid systems, internal jugular vein, all the nerves, vagus nerve, hypoglossal nerve, everything is there in the parapharyngeal space. So the most important thing here, what I wanted to ask is, what is the difference in the incisions for infective pathology as well as or versus tumors? What are the different factors which play? When, see, for example, this was a swelling in the parapharyngeal region, but now if it would have been a tumor, what is the factor? Like, what is the difference in the incision? And the second is, if it would have been an infection, what is the difference in the incision? Anybody? Yeah. Incision should be gravity dependent. Okay. Correct.
If the tumor is malignant, you need to have sufficient margins around.
Okay. If it is a tumor, you have to access to that. This is what Dr. Mustafa has already told. The access is the most important thing. If it is a tumor, you have to access to that tumor, right? So for that you should know that where it is. Okay. So now we are going towards the next session. So access, length of incision. If you are dealing with the infections, your length of incision has to be smaller because you have to drain the abscess only. That's it. Okay. The third thing is identification of important neuromusculovascular structures. That holds true for both the things like for the tumor extirpation as well as for the infections. But in infection, you sometimes can go blind, keeping in view that there can be important neurovascular structure at this place. For example, for the parapharyngeal or lateral pharyngeal space, or from in the carotid space, you have to palpate the anterior border of the sternomastoid muscle, and you have to give the incision there, as well as in the lower border of mandible, 2 cm below the lower border of the mandible, and you can direct your hemostat like Hilton's method, and you can drain the pus. But in case of tumors, you have to adopt a different surgical approach that will come in the neck when we are going to discuss in the neck session. Okay, so and the third one is the extent of dissection. For the tumor extirpation, your extent of dissection has to be elaborate, and for infective pathologies, your extent of dissection is not at all required. You just need to go to the, like Dr. Andrew has told, give the incision, put your finger, feel the loculi, reach up to the abscess and puncture it, okay, so that the pus can drain. Okay, sir, you wanted to add something?
Yeah, the last point, this is something I forgot to mention in my lecture. When we showed that transbuccal incision for BSSO, so as we said earlier, that any incision, the most important criterion is the exposure. So good access and exposure. So for a BSSO, if you want a better exposure, so once you have raised the flap, just put a what is that? Coccus.
Coccus.
Okay, on the anterior border, especially at the coronoid process, put it and clamp it. That will give you exposure to the entire medial aspect of the ramus or the lateral aspect of the ramus. Thank you.
Right. And you, sir? More points of wisdom. Any question you want to ask them? Otherwise, I have another question.
Let's go to the next question.
Yeah. Which of the following statements about the anatomy of the trigeminal nerve is false? We are taking you back to the basics. No, just raise your hand, please.
That last girl there.
Yeah.
Speak up.
Speak up. Correct. Yes, correct.
Well done.
Okay.
Ready?
Come on, Mustafa.
Oh my god.
Oh my god. So it is oculomotor. Actually the third branch is ophthalmic, maxillary and mandibular. Let's go back to, we have 2-3 more minutes. We have not discussed about the distraction incisions. Sir, Andy sir.
Yeah, I mean, I don't do a lot of distraction now. I used to do a lot of distraction. Distractors have changed dramatically over the last wee while, basically. Whether it be intraoral or extraoral distractors, basically, yeah.
If you can comment on the fresh incisions or the already existing incisions. This is what we wanted to discuss here.
We know fine that, you know, extraoral distractors scar quite significantly, and I think there's been a sea change now to providing intraoral distractors, multi-vector intraoral distractors rather than the old-fashioned conventional one-vector or bi-vector ones that I grew up with, basically, which were all extraoral, basically, and you stuck them in, you know, for treating cases like hemifacial and all that sort of stuff. I mean, I assume that that's an ankylosis case, is it? I would imagine, or apology for that. We don't see ankylosis in the UK. It's very, very, very rare. The only ankylosis cases I've treated are here and in Pakistan. I've not treated any cases in the UK, basically. But distraction, I don't do a lot of now, basically. And if I am, it will be intraoral, small intraoral distractors, basically.
So, Dr. Sonal, would you like to comment on incisions about when you have to plan for distraction, intraoral, extraoral, what factors?
Right, so basically this is a very, I mean I can talk the whole day about distraction and ankylosis, but suppose
talk for 1 minute.
So, this case would actually require, I mean maybe next year if you guys come back we'll talk about this again, but this case would require a biplanar distraction, okay? So that because here, if you see the CT, And when we measure the CT scans and everything, you will see that the body is short as well as the ramus is short. So basically you need to grow the body as well as the ramus. Now therefore you need two incisions, you need an incision that will cover both the places, either that or you need one incision through which you can go to both the sides. Now that again depends on where you want. So what we would do here is we would place a periangular incision. Okay, a periangular incision may be slightly more extending it slightly more anteriorly, because through that anterior part you can reach the body, and because it is periangular going up to parallel to the posterior border, you can reach the second cut. So there will be one cut in the body and one cut in the ramus. Okay, so through a periangular incision you can reach here as well as here. That is if you are doing distraction. These days, because a lot of cases you can be dealt with doing a TMJ replacement, okay, a joint replacement. So if you are doing a joint replacement, then as sir had said, that you also have to understand that you have to deal with the lengthening of the ramus. The final length of the ramus will be more than what it is now, right? So as of now, if you think, okay, this is the lower border, let me place my incision 3 millimeters below that, that will not be the final incision, okay? The ramus would have come down. So the ramus would have come down, and your incision will be right here on your face, on the patient's face, right over here. So you don't want that. So you have to plan for how much lengthening you are going to do. According to that planning, your incision has to be there. So if I am an ankylotic patient, if my ramus is so much right now, and if it has to come till here according to your measurements, then your incision will be here, not here.
So it is a very valid and important point that in case of distraction, your incision has to be a futuristic incision. Yes. That where your anticipated futuristic incision, where you want your mandible to come after
futuristic incision if you are planning for a TJR. But if you are doing a distraction, then as she mentioned, periangular will do the job.
Yeah, for futuristic incision for TJR also, TJR is always generally done with the virtual surgical planning. So we know that how much lengthening and how much widening and how much anterior forward movement of the mandible we are going to get when we are placing the TJR. So it's a very valid point by Dr. Mustafa also, that these are the futuristic way of thinking about the incisions when we are dealing with these kind of deformities. Thank you. Should we? Okay. So how many? Who has won the maximum number of chocolates? You have not yet made your presentation. Thank you very much.
Any questions? One last question. We are waiting for my team member to come. Yes. Speak. Okay. Nobody will come to the mic.
There is a right angle screwdriver available in the market. So can we avoid external incision?
Yeah, I'll answer that in the TMJ section. Right angle screwdriver is for the condylar fracture fixation, which comes under TMJ.
Yes. Can we use it in a
even for an IVRO it can be.
Yeah, even for the angle fracture also, even for the ramus fracture also we can use it.
Yes, you're reaching there. Therefore, all of that will be dealt with in the TMJ section. So we will take the questions in the TMJ section. But yes, you can use it. How to use it, we will tell you in the TMJ.
Thank you.
Any other questions?
One more question.
First, you're a surgeon, na? Screen. If it is uniplanar distraction, then also periangular incision. No, then if you're only doing a body incision, osteotomy, place a body. You can either put a heavy high
Submandibular incision.
submandibular or a high submandibular.
Any other question? Any other doubt? Any other question? Okay. Thank you very much for this wonderful session. Thank you, Sonal. Thank you, Andy sir. Thank you, Dr. Mustafa. Thank you, Richa. Thank you, Lakshmi.